Look at human cellular tissue. On one side, cells are actively degrading and shriveling. On the other, they're swelling with an excessive accumulation of lipids. Both of these extreme physiological states are the direct result of a single failing input: nutrition. The World Health Organization strictly defines health as a state of complete physical, mental, and social well-being. This biological baseline is defined by the presence of these wellness markers, going past the basic absence of disease. Your nutritional status is the direct physiological output of the food you consume. When that system fails, we categorize the resulting condition as malnutrition. Clinically, this encompasses both undernutrition, a severe deficit of materials, and overnutrition, where an excessive supply overwhelms the body's metabolic capacity. Treating a malnourished patient requires diagnosing a complex systemic failure. It is rarely a matter of simply adjusting the volume of food on their plate. To accurately assess a patient's health, clinicians have to deconstruct their nutritional status into its component parts. We use a multifactorial matrix to understand exactly how an individual absorbs and utilizes the calories and nutrients they ingest. This matrix accounts for 4 distinct categories of variables acting upon the patient: biological, environmental, lifestyle, and cultural. Effective clinical assessment depends on mapping this specific web of variables. A dietary prescription will fail if it ignores the external forces acting upon the patient. Before evaluating those external variables, we have to establish an absolute physiological baseline. We start with the basal metabolic rate, or BMR. This is the strictly quantified energy required for vital resting functions, such as breathing, blood circulation, and baseline brain activity. The human body extracts the energy to drive these functions from 3 specific macronutrients: carbohydrates, proteins, and fats. This chart displays the exact energy density of those macronutrients. Carbohydrates and proteins yield identical outputs, exactly 4 kilocalories per gram. Fats carry a significantly different metabolic weight, yielding 9 kilocalories per gram. They hold more than double the energy density. This 4-9-4 kilocalorie rule establishes a uniform biochemical baseline for human metabolism. Yet, the moment we apply this rule to a real patient, that theoretical baseline is immediately distorted by their individual life variables. This flowchart outlines the primary clinical framework used to assess those precise variables. Let's look at the specific vectors that alter a patient's BMR. We begin with the inherent biological modifiers: age, sex, and baseline health status. Age and sex directly dictate nutrient demands. Growing children require a distinctly higher intake of fatty acids to support cellular development compared to adults. An existing disease state will also actively rewrite nutritional requirements. Hypertension necessitates a strict low-sodium intake, while a diabetes diagnosis requires careful limitation of carbohydrates. From internal biology, we move to physical modifiers, specifically a patient's level of activity and physiological stress. Muscular exertion creates a massive metabolic demand, but cognitive effort does not. Intense mental tasks require an output of only about 4 kilocalories per hour. Psychological stress exerts a powerful influence on the body, driving completely opposing clinical outcomes depending on the individual. In a stressful environment, one patient may suffer severe undernutrition by heavily restricting intake, while another may engage in hyperalimentation, consistently overeating. A patient's current biological condition and physical output entirely rewrite their theoretical caloric baseline. Climate and geography act as hard physical barriers to nutritional access, dictating if a local population relies on staple crops such as rice or fields of wheat or harvested maize. An over-reliance on a single geographic staple has historically triggered severe deficiency diseases. Populations consuming primarily highly milled raw rice frequently developed beriberi, while pellagra emerged rapidly in communities dependent almost entirely on maize. Returning to our framework, we find another set of variables that firmly constrain nutritional access: socioeconomics and lifestyle. There is a direct, measurable correlation between a patient's income level, their educational background, and their ability to purchase and prepare hygienic, balanced meals. A clinician can write a theoretically perfect diet, but that plan remains irrelevant if the patient's socioeconomic environment cannot sustainably provide the required food. The final major vectors in our assessment framework involve a patient's cultural practices and traditional factors. Religious mandates routinely enforce absolute dietary rules. During the month of Ramadan, practicing Muslims abstain entirely from all food and drinks from sunrise to sunset. Deeply rooted cultural food taboos also menstruation. Pregnant patients may also exhibit conditions like pica, which is a craving for non-nutritive substances like clay or chalk. We also have to account for pharmacological interference. Medical treatments like chemotherapy and radiation cause toxic side effects, such as oral ulcers and intestinal complications, that physically block the body from absorbing nutrients. Clinical assessment must navigate these cultural and medical realities carefully, as they frequently override a patient's basic biological hunger drives. This diagram outlines exactly what happens once a patient's inputs are metabolized, producing 5 distinct physiological outputs. We start with the physical outputs. Proper nutrition provides the foundational building blocks for physical growth and directly fuels the immune system to combat surrounding infections. Critical vital functions are maintained by dietary proteins. The body requires amino acids to build and repair tissue. Because of this cellular maintenance, balanced nutrient intake directly mitigates the risk of chronic conditions like coronary artery disease and diabetes. But these outputs extend past strictly physical health. Intellectual ability and mental stability are rigidly tied to specific nutritional intakes. Take the biochemical pathway of tryptophan, for example. It is a specific dietary amino acid that the body requires to synthesize the chemical serotonin. That continuous serotonin synthesis is clinically required to regulate normal sleep patterns and manage depression. Nutrition is not a passive state. It is an active therapeutic tool that dictates systemic outcomes, reaching from cellular repair to cognitive stability. Because of these multifactorial complexities, the science of nutrition has expanded beyond the isolated chemistry laboratory. Today, it operates as nutritional epidemiology. This broad discipline tracks variables across massive populations to inform global health policies and combat non-communicable diseases. For the modern clinician, patient care requires seeing nutrition as a dynamic, lifelong interaction between a patient's biology and their environment. The simple caloric transaction is only the first layer of the clinical assessment.